Okay.
Hi, Caroline. Thank you so much for joining us today.
It's a pleasure to be here.
Kathy and I are super excited to talk to you and hear about your clinical experiences. So, first, we just wanted to offer a warm welcome and just learn more about who you are. And can you tell us about kind of some of your professional experiences and education that led you to this point?
Yes, of course. So I'm a licensed clinical social worker. I got my bachelor's in arts from George Mason in psychology, and I realized I wanted to be able to go into a clinical field. And so I pursued my master's in social work at Virginia Commonwealth University, where I had a clinical focus. And from there, I was able to get hired at the State Psychiatric Hospital in Northern Virginia, where I worked for 7 years altogether postgraduate school and earned my clinical license while I was working there with the seriously mentally ill population, mostly patients with schizophrenia. We had patients that were either civil patients, involuntary civil, as well as forensic patients. So we had patients that were not guilty by reason of insanity for committing crimes while they were often psychotic, as well as patients who had been committed by family members or through the legal system, as well as patients that might have been there voluntarily as well. And after I left the state hospital, I got hired in 2005 to work at the VA in Washington, D.C. in the mental health service line. I worked for 2 years in the inpatient psychiatric unit with veterans with mental health and addiction issues. And then from there, I transitioned to an outpatient, intensive outpatient program called the SART program, which was a substance abuse clinic. It was an intensive outpatient program. IOP is the term that we usually use. And that was for veterans that were mainly coming into the clinic due to the primary reason for coming into the clinic was due to substance use disorders. But most of those veterans were also dealing with significant mental health issues, including complex trauma. And so we often saw a lot of veterans in that clinic that were self-medicating a variety of issues, including PTSD. And so we were treating a lot of alcohol use disorders, opioid use disorders, stimulant like cocaine use disorders. And so we did have like a methadone maintenance clinic in that particular location, as well as a buprenorphine maintenance clinic. So we saw a lot of veterans that had like complex psychiatric substance abuse as well as issues with medical problems. And because the VA in Washington, D.C. is located in an inner city urban area, we also saw a lot of economic impoverishment. So we had a lot of veterans that were homeless, a lot of veterans that were literally living in the streets, sleeping in cars, sleeping on park benches. So we would often get them linked to resources to help them to be able to live more stable and more fulfilling lives. Some veterans did extremely well with supports, and others unfortunately preferred to live on the streets because of a variety of reasons, sometimes mental health, sometimes addiction, and sometimes a combination of the two. But the VA had a lot of wonderful resources that we were able to get them linked to, and loved working there. Worked there for 14 years. And from there, I ended up going to Inova. So I've been with Inova for almost 6 years. And I started working in an integrated mental health setting, which basically means primary care physicians and nurse practitioners can refer a client with mental health concerns that come into primary care to behavioral health, which was a therapist like myself. And then we would assess them and provide counseling as needed. And from there, I more recently, in the last 2 years of my work at Inova, I've been working in a perinatal mental health program through women's behavioral health. So we work primarily with women who are either pregnant, dealing with fertility struggles, as well as women who are either 1 year post, up to 1 year postpartum from having a baby or experiencing a loss. And so we have women that we're working with who might be pregnant, who might be undergoing like current fertility treatment, women that have had miscarriages, women who have needed to terminate pregnancies for medical reasons and are extremely grief stricken and have a lot of complex guilt about that. I have a client right now who chose to terminate a pregnancy after 20 weeks after learning that the child had Down syndrome. I've had patients who have had stillborn, like one patient in particular had a stillborn child. I've had a couple patients that have had like second term miscarriages, which are more unusual, but they do occur, unfortunately. And so those usually are more complex loss issues that we see. And so we definitely work mainly, I would say, with a population more in the like the millennial age bracket, because they're the most likely to be able to have a child in terms of being of childbearing age. But we also are opening up the clinic to being able to serve perimenopause patients, which I think is wonderful because many women in my age group are marginalized in terms of their physical and mental health needs. And so that is actually being discussed, and they're trying to figure out how they can include more patients who might be struggling with everything from hormonal shifts that are causing them to have, you know, depression, insomnia, anxiety, night sweats, etc. And so they're seeing more referrals through like the medical side, but we haven't yet gotten, I haven't at least gotten any referrals for those patients for counseling services. So with counseling in the ANOVA program, we normally will get the referral from the OBGYN, or we will get it from sometimes breastfeeding medicine, or we'll get referrals from the NICU, because we have patients that often are dealing with a lot of postpartum stress because the child has been born prematurely and they're in the NICU and they're dealing with stress related to that experience. So we also get those types of referrals. So we really do see the gamut in terms of complexity. Some patients are certainly a little bit more simple, like they might have more adjustment related anxieties about being pregnant or being, shortly postpartum after having a child. But we do have patients that have like full-blown PTSD from having like a significant labor and delivery trauma. Like one patient of mine had such a bad hemorrhage that she almost died. And during the course of her delivery, she had difficulty articulating that she felt like she was going to vomit while they were giving her pretty heavy duty opioids, and was worried that she would literally choke and aspirate. And so we did a lot of work together surrounding her second pregnancy, because the first pregnancy was so traumatic. She had a lot of anxiety about her subsequent pregnancy. And I'm happy to report that even though the second delivery didn't go exactly as planned, it was a very like healing experience, because she was able to get her needs met, and she felt like the team really cared and listened to her. And so she was successfully discharged after a year postpartum with that child, and had actually come and did a presentation about our team and all of the things that she was able to glean from her work with me and with her other providers. And one thing that's really nice about the Women's Behavioral Health Division, where I'm currently working, is we're very interrelated with other team members, because we have direct correspondence with like OBGYN and labor and delivery and NICU. And so my director goes to Fairfax Hospital and has meetings there regularly and makes sure that, we're streamlined. We have 2 psychiatrists dedicated to our program. A lot of women who receive services from us are also seeing a psychiatrist for medication and symptom management. And so that's one thing that a lot of programs don't always have. When I was with the integrated program initially with ANOVA, we often had to beg for a psychiatry consultation, and we often would reach out to the primary care provider to provide medication if needed as a bridge before they could see the psychiatrist. But our current program has more resources, so we've been very fortunate in that respect. There are foundations that actually donate towards women's behavioral health for ANOVA.
Wow, that's really amazing. As I kind of listen to you and I'm reflecting on all of your experiences, I really appreciate the rich and very extensive work that you've done in the field. And it was kind of nice to even hear kind of work that you've done in the past, what you're doing presently. And also you shared what your current agency is going to be doing in the future. And so it's kind of nice to see that full timeline and just that impressive range of all that you're doing and all that you're contributing and that you have contributed. I wonder if we can go back in time a little bit. As you were at the threshold of graduating with your undergrad degree, and you said that you knew you wanted to go into clinical work. Can you tell us a little bit about what made you realize that you wanted to go into clinical work, and why did you choose social work?
So I've always been a very naturally curious person. I've always been very inquisitive and interested in people. And my late father was a journalist and had raised me with many, many questions over the years. And so I think in terms of my mental health interest, curiosity certainly is a huge factor in my search for a field that was able to satisfy a lot of questions that I often have about the human condition. And certainly, I always want to learn more about myself as well. And I find that through learning about others and searching for answers from others, I'm also often learning and getting answers for myself about my own experiences. And so in that way, it can be rewarding, even if I'm not focused on myself during a session, which certainly wouldn't be appropriate. There's still a lot of insight that I often am able to gain from those meetings. For example, I was talking with a client the other day who was describing some pretty existential crises in terms of feelings of isolation and feelings of a lack of freedom. And we talked about how that can really create a lot of anxiety and a lot of unhappiness in terms of the human condition. And she had never heard of like specific crises, but she's like a PhD educated young woman who recently had a loss and has been separated from her husband as a result. And as I was talking to her about the existential crises that I saw her kind of describing in the theme of our discussion, I also had sent her an article about some of these existential crises and thought about them as well, because, you know, one of the reasons I left the VA was I felt great meaning and purpose by working at the VA, but I also felt a lack of freedom because of my very long hours and long commute. And I had very little time in terms of like personal time at home. And I found myself being chronically tired and often getting ill because you're exposed to a lot of illnesses when you work in a hospital setting. And so there was this feeling of the golden handcuffs where I really enjoyed the work and there were great benefits and it was very fulfilling and meaningful, but I felt in some way trapped by it. And so that was something that I grappled with for a couple of years before I left the VA. And thinking about that and how it, you know, many of my patients are experiencing very similar crises. And so I'm able to identify and I'm able to at times use therapeutic self-disclosures to normalize their experience and to also make sure that they know that they're not alone and that there's a name for it.
Yeah, I think that's really amazing work that you're doing. And I like that you identified the quality of curiosity. I think curiosity is such an important element in the therapeutic field. And I think it's one that we don't really talk as much as we should. But it's so important as you're learning about others, hearing their story. And I think that that curiosity is really a driving force. And also it can lend itself to the rapport. You know, we all appreciate when somebody's curious about us. And so that really contributes to the dynamic. And so I appreciate you identifying that, as well as kind of the parallel process of as you learn about others, you learn about yourself and vice versa. It's also really interesting to hear you talk about your working at the VA. And I think it is very common for people to have the experience of liking certain aspects of a job, but maybe others are undesirable, and how that can really cause an existential crisis. And it sounds like you were really helpful in naming that and kind of a voice to your client as she was learning more about that. So in a way, kind of the curiosity you demonstrated goes both ways in terms of she had never heard of that phenomenon, and you were able to provide her with insight, which sounds like it was really meaningful.
Yeah, and you had asked also about social work in particular and why I pursued social work. So there were a few reasons. One was I've always enjoyed being able to do things for people as well. And in the field of social work, you don't only provide clinical work, you also provide like tangible case management work where you might help someone get a home or help someone pay an electric bill or help someone get food in their pantry or help them to be able to get a driver's license or other things that they know that someone helped them and it made a difference for them. And so I don't do as much of that kind of work at the Inova clinic because I'm mainly doing clinical work, but I do advocate and get, patients linked to like the doctor and other resources in that regard if they need like an extension for like reasonable accommodations or short-term disability. We help them, and I find myself advocating. But at the VA, I had a really nice kind of dual role. I did a lot of clinical work, including like individual, group, and family work, but I also did a lot of resource linkage. And in the social work world, you're looking at kind of this ecological approach. So you have the person in the system, and the system includes family, it includes maybe a religious entity, it includes, their home environment, it includes their greater community, their culture. And so you get to be able to link people to the needs that they have in terms of like patients that were living on the street. We would get them linked to VASH vouchers, like HUD VASH. Like the VA actually worked with the housing and urban development and got Section 8 vouchers that they would then case manage. They would hire social workers from the VA to provide case management to those veterans staying in a Section 8 home. And so I had veterans that would come to see me afterwards and they would say, I'm not living on the streets anymore because you helped me get access to an apartment. Or I would refer them to maybe an inpatient facility if outpatient where we were treating them wasn't substantial enough. And they would come back from, Martinsburg, for instance, if we sent them to a domiciliary there for substance abuse treatment. And they would say, like, it was the best experience I've ever had. I wish I didn't have to leave. And so there was definitely a reward in seeing people like recover and be able to reach their full potential. But also these tangible things are things that allow you to build trust with patients because you can show that you can be counted on. If I tell someone I'm going to sit with you and help you with your social security situation, and we'll call social security together, or we'll, call, the court together to make sure that you don't have any issues with the court, and I follow through with that, that helps to forge that relationship because the person knows that I'm reliable, that I can be counted on. And even if it's not necessarily like a therapy intervention, there's still clinical relevance because that person is more likely to feel comfortable to talk to me about more complex or deeper level issues because they trusted me to help them with something so basic.
Wow, that's so meaningful. And I really like you describing kind of the essence of a social worker, and you use the word systems. And it's so true that a client doesn't live in a vacuum, that exists in the client, in the clinician's office. They live in a great big world, and they have families, they have communities, and they're engaging with those systems on a regular basis. And I like that aspect of resourcefulness and connecting clients with resources. And I also like the way you painted a picture of how connecting clients with resources has that practical, pragmatic aspect, but it also really builds the clinical rapport, and it really lays a foundation of trust. And so it's really multifaceted, which is really an interesting way to think about it.
Yes. I've had patients that have come to me in a more guarded stance, especially at the VA. We served primarily African American male veterans, and many of them had been traumatized in the military due to a variety of things, including racism. And a lot of them had pre-morbid trauma from childhood and young adulthood. And sometimes there was a lot of fear about the medical community and fear about getting mental health treatment. There was a lot of stigma. And so they would often come to me with something very small, like I need help with like getting clothing, because their clothing would get stolen because they would leave it at the park, or it was stolen at the shelter. They were literally coming to the clinic with only the clothes they had on their back. And sometimes they were hungry, and I would have like a banana on my desk, and I would say, here, take the banana, eat, and then we'll talk. And so those small exchanges made such a difference that they felt more comfortable coming to me with bigger issues. I had one veteran I'll never forget that came to me, and he couldn't pay his child support. And he was getting all these letters from the court, and he had had a stroke. So he couldn't work like he did before. And he was still being held responsible for this child support, but he could not pay the child support. And they had subpoenaed him to court. As we worked together, I realized he could not read. He was illiterate, and he was so ashamed of it. But after working together, he was very forthcoming with me. I started reading to him the letters. We started calling the court together. I helped him apply for Social Security disability income. He actually got the benefits approved. He was able to reduce the benefits that he was going to owe for child support based upon his current income. And he felt so, not only such relief, but he felt heard, and he didn't feel ashamed anymore, because it wasn't like a secret he was holding anymore. He couldn't write more than his name, and nobody really knew except for a very select few people. And so those small things, even if they don't seem like as clinical to the outside viewer, they're really meaningful in terms of like the social work experience and being able to like help someone for the greater good.
Oh, absolutely. You know, as I listen to you, I think about Maslow's hierarchy. And if you don't have those basic needs met, if you don't have food in your belly, how are you expected to kind of think about things more abstract and existential, such as the meaning of life? You really need to have that layer, that bottom layer of those foundational issues met. I also, as I hear you talk, am just so impressed in the massive difference that you make in people's lives, and just how gratifying that must be.
It definitely is gratifying. It's also humbling. I've often told my children that they have no idea how most people live. They're living in a bubble in a suburban community when most of the world has many more struggles and perils that they're faced with on a regular basis. And a lot of the veterans that I served would recall, living without lights on when they were young because they didn't have the money to afford the electric bill. A lot of them had recalled going from family member to family member, not always having food on the table, having to like stay with aunts or uncles or grandparents because the parents were either incapacitated in some way or incarcerated. And so a lot of times the things that we often take for granted are things that are really not to be taken for granted in terms of like stability and security and like a roof over our head and food on the table. And so I've often reminded my kids who have truly been born with a silver spoon in their mouth how lucky they are, and how they are really, they have no idea what many people have to survive, and the level of resilience that we often see in the work that we do. People that easily could have given up that have still pushed forward and are coming to the clinic, or they're coming to the hospital for various services. It's not that they don't feel pain, it's that they have that, tenaciousness despite the pain. And that's something that
Mm-hmm.
I often reinforce in my clinical work with clients when they've been through unimaginable experiences, that what defines us is, how we're able to eventually cope with those obstacles. And it's normal to have a painful reaction to those particular struggles and adversities. And so oftentimes people have to shift their mind to think, okay, it's okay that I am feeling pained by this. I am capable of being able to make it into something that's meaningful and maybe give back to someone else who might be experiencing what I have experienced. And so that's really a lot about, like, when we talk about recovery from a lot of things, especially in addiction. One of the things that people are encouraged to do once they have at least a year's clean time is to be a sponsor to someone else, to be able to give back to the community. And we had like peer support specialists, for instance, at the VA that would be hired to help their peer veterans who were still going through treatment, who were still having crises, to mentor them as a peer. They were a paid peer and they were certified and trained, but they themselves were recovering from a mental health and or substance abuse issue. And it was really gratifying at the VA to see two former patients that I treated become peer support specialists on a team with me, where I was meeting with them as a colleague versus me being their social worker.
Oh, I love that. I think about the gift of giving and how it's so meaningful on the part of the person doing the giving and receiving. And it's really kind of a two-part system. I really love that. I also think it's really special that you talk about client issues to your kids, and in that way, you're giving them kind of the gift of perspective, which I think can be really important and as you mentioned, humbling. You mentioned that. You mentioned the concept of resilience, and as you were talking, I felt a really strong strength-based kind of approach that seems to be who you are and what you provide in the clinical space. It seems as though you point out areas that your clients have strengths in that maybe they don't necessarily see themselves, and I think that vision and that clarity can be so important in helping people move forward. And I wonder if we can talk about approach a little bit. I'm so curious to hear kind of your style and your approach and theories you use, and especially since you've practiced across so many different contexts. Can you to us a little bit in terms of, do you see continuity in your approach, or do you see your approach shifting from context to context?
I often, in the current clinic where I'm working, I see my approach changing based upon the particular client that I'm serving, as well as the client's needs and their personality style. I have some clients that I can tell want to be more structured and focused. And so I might use more of a cognitive behavioral approach with them, and we'll practice using thought logs together. Whereas I have other patients that really want to process more, and they don't want the parameters of a more structured behavioral, cognitive behavioral health approach. And so I really try to individualize the treatment. The client that I was referring to earlier, who she had actually messaged me about how, like, she learned from the article about existential theory and crises. She actually said in her email that she wanted to talk about her issues with freedom and isolation during her next session in more depth. And so for her, I'm not going to be using a lot of cognitive behavioral therapy in the traditional sense, even though I might incorporate some techniques that won't be the focus. We'll be focusing more on the existential issues and how she might be able to cope with some of those issues. Some of the coping might be more behavioral in nature, but it also can be more strengths-based in terms of finding ways that she can feel more empowered. Whereas I have some clients who are having a lot of issues with their relationships, and oftentimes I'll do role plays, which is more of an interpersonal therapy approach, which I find really helpful, because not only does it help model open and assertive communication, but it can be a cathartic exercise, and it can also often reveal underlying themes that I might not be aware of and the client might not be aware of. And I'll give you an example. Today, I had a very meaningful discussion with she's relatively young. She's 41. So she's an older parent, but compared to me, she's young. It's all relative these days. She has a 3-month-old baby, and she has a husband who she reports is on the spectrum. My guess is he probably has what used to be called Asperger's. So he's functional, he has a job, he's able to do, the things that we would expect from a, productive adult, but he does have, according to her, some emotional and social limitations. And she talked about how she has a lot of anxiety about her son and about something happening to herself. So a lot of her anxieties are surrounding health and safety for herself and her son. And she talked about how she was upset that her husband seems to be, she didn't use these words, but she described him as a bit withdrawn and not as involved and not taking initiative with the care of her son. And as we did the role play, she became very emotional. And she said, I'm realizing that a lot of my anxiety and sadness about the situation with my husband is revolving around my childhood. Her father died when she was 4 years old from cancer. And she said, she became tearful, and she said, while we were wrapping up our role play, that it dawned on her after, while we were doing the role play, that she wants to give her son what she didn't have. And that's why it's even that much more important that her husband have a more active role in her son's care. And it was like a light bulb went on. And for me, it was also enlightening because I had not put 2 and 2 together at that point until she mentioned it. The other thing that came to light from the role play was she acknowledged, because I first was her and she was her husband, responding for how her husband would respond. And then we switched and I was him and she was herself. And as I assumed his role, I started to feel a sense of helplessness and a sense of feeling like I wasn't competent as a father, because she had made a lot of comments about him not doing things right. Like he didn't wash the bottle properly, there was milk on it. When he holds the baby, there's a blanket that she thinks is too heavy and the baby might sweat. And so through our role play, I was expressing some of the underlying themes to her as her husband, even though her husband is not expressing them. Like I said things like, I just feel like I can't do anything right. I feel like I am, like you don't like trust my competence. I feel like, the things I do are criticized. And so by the end of our role play, she actually admitted that she can be quite controlling because of her anxiety, which has actually alienated her husband from being more involved. Because she said there are times when he wants to sit with the baby and she's criticized him for using the blanket, or she's criticized him for not doing something the way she wants it to be done. And at the end of the session, when we were able to glean a lot of these realizations, I said, I can't make this decision for you, but it sounds like there are things that you might be able to let go of control-wise, and there are things that are very important that you maintain control of. And I said, it will be important for you to think about the things that you are willing to let go of so your husband can be more involved. And so on her own, she said that she would be willing to let him hold the baby while she went upstairs and did something else, because normally she's watching him like a hawk. Mm-hmm. And so it was a very insight-oriented experience because of the role play. Mm-hmm. And so at first I could tell she was a little embarrassed, but once she got in the swing of it, it was a very meaningful modality of treatment. And interestingly, I didn't realize this. I've been using role plays on and off for many years, but when I went to a perinatal mental health training back in November, one of the interventions that they said, besides cognitive behavioral therapy for perinatal patients that's most effective, according to the research, is interpersonal therapy, which often utilizes role play exercises because of interpersonal issues with
significant others, often postpartum. I think that is so amazing. First, I just want to comment on what you said earlier in terms of how you really individualize your approach to the client's needs. You can kind of scale up and down in terms of how structured or how open-ended it is. And I think that really is important because no two clients, even if they're navigating a similar issue, no two clients are the same. And I think that really shows that you're able to tailor make your style to meet the clients. I also really love hearing you talk about the role play and the benefits of role play. And it's almost like you're integrating a naturalistic element into the clinical space and understanding those interpersonal dynamics. And, you know, what's striking to me is not only is the client able to maybe empathize with, in this case, their partner, but you also are able to empathize with what the client and the client's partner is going through. And that helps kind of sculpt the therapeutic process. So that is real. I mean, it sounds very holistic and comprehensive, which I think is really amazing. Thank you. It's always illuminating when some of these themes are uncovered, and sometimes they're surprising. I remember. Yeah. Mm-hmm. Oh my goodness. Yeah, those aha moments. And I would think that, you know, when you're kind of you're simulating a conversation, all of those kind of organic themes come to the surface more than if you're logically reporting on what the dynamic is like. It really draws from two different parts of the brain. Yes. Mm-hmm. I wonder if you would be willing to do a little role play, just so viewers can kind of see what that might entail. You know, how things could maybe bubble up from the surface, because it sounds like a really impactful process. Absolutely. What kind of scenario would be helpful in terms of a role play exercise? So you mentioned that you talked with a previous client about some existential issues dealing with workplace issues. And I feel like I wonder if we could maybe do a role play with that, just because it feels like it's probably relatable to most people at some point in almost everybody's life. They might have some dissatisfaction with work. And so maybe I can report some feelings of dissatisfaction or depression or anxiety that's kind of stemming from not being pleased with a workplace experience. Okay. Wonderful. So I'll pretend to be the therapist and you'll pretend to be the client, and yes, you're coming to me to talk about some of your work-related stressors? Exactly. Okay. And would this be like, this wouldn't be an intake per se where I have to ask lots of like assessment questions. It would be like, hypothetically, maybe a follow-up session. Exactly. Okay. So how are you doing today? Oh, I mean, I guess I'm okay. I mean, I don't know. I feel a little listless, and it makes me feel guilty because I feel like I have so much to be grateful in my life. But sometimes I just feel like I'm going through the motions, and then I stop myself and I'm like, what are you doing? Like, you have so much to be thankful for in your life. Tell me a little bit more about this feeling of listlessness that you're describing and some of the guilt associated with it. Well, I mean, I'm not expecting to like jump out of bed and, you know, start the day like with, you know, a bluebird on my shoulder, but I do feel like, you know, looking forward to the day at least, and having a little bit of energy would be nice. I just feel like I'm always dragging. Like I drag myself out of bed. I feel like, oh, it's Monday. Oh, it's Tuesday. I feel like honestly, the only time I'm happy is when I'm leaving work on Friday. And, you know, as you know, we spend so much time at work. And then Sunday night, you get that depressive, like, oh, I have to start it all over again. You know, and I hate to just complain about that. I know most people don't love their work. And so why should I be complaining about this? I have a good salary. You know, my work gives me benefits, but I don't know. I feel like it's weighing me down. It sounds like the movie, and I often think about this in many of our scenarios, the movie Groundhog Day, where the person's going through the same day over and over and over again. And there's this sense of like
oftentimes like monotony, and what you're describing is also a sense of dread on Sundays. Like some of my clients call it the Sunday scaries, where you're thinking about all the things you have to do in preparation for the work week, and each day takes a great deal of energy to survive. And so you're not really living, you're just surviving. You're in that kind of fight or flight mode of just trying to survive. And you mentioned often being very fatigued and tired. You mentioned initially feeling listless, but I'm wondering, like, how are you sleeping in terms of like your overall mood? Low energy can be a symptom of anxiety, it can also be a symptom of depression. And I'm wondering for you, like, how are you sleeping? How are you eating? How would you describe your mood lately? I know these are a lot of questions, but you can answer them at your own pace.
Yeah, I feel, first of all, I really relate to that movie Groundhog Day. I didn't think about it. I haven't seen it for a long time, but that does feel like that repetition of just like, over and over, like like being on the hamster wheel of life and everything's just like the same. So that really resonates with me. In terms of sleeping and eating, I have to say it's not the best. I feel like when my days are so busy and full, and so I wind up eating a lot of junk food. I'm so tapped out when I get home from work. I just wind up just like chilling on the couch and eating, something I throw together. My sleep is not great. I wake up sometimes at 4 a.m. and I start feeling nervous, like, oh my gosh, I have to wake up in 3 hours to wake up. And so I start perseverating on that, and that keeps me up. And then I wind up falling asleep maybe around 6:30 and getting a half an hour. Then I wake up groggy, and it feels very cyclical and Groundhog Day-ish.
It sounds completely exhausting and unfulfilling. What do you think it is about your job that has been so draining and so unappealing in terms of like the day to day?
Well, I guess I went into accounting thinking, I was always really good at crunching numbers, and I thought, oh, I'm good at this, I might as well get a job in this. And I am good at it, but it doesn't give me any purpose. Like, especially after COVID, I'm like, I felt like people started questioning things like, burnout. And I realized I don't get anything from my job. I don't get any give back. It just feels like I'm going through the motions, and I'm good at it, but I want to do something more. I don't know. I want to work with people and I want to be helpful. And not to say that accountants aren't doing those things, because, you're very helpful as an accountant. But me personally, I guess I just want to exercise another part of my personality. So I don't know, maybe it's the job duties themselves. I mean, my boss is great. Everything seems, the salary is great. That's kind of what's keeping me there. But I guess it's really just like the job duties are starting to grate on me.
Mhm. I mean, it's definitely like the golden handcuffs that you're describing. You're mentioning like the benefits are good, your boss is nice, you get paid well, but the work is unfulfilling. You don't find meaning and purpose in the work that you're doing, even though you recognize that people need accountants and that you are providing a service. There isn't as much intrinsic motivation and fulfillment from the actual work. And so I'm sensing that there's a couple of existential themes that you're describing. One is like lacking that meaning and purpose. The other is possibly feeling like you're trapped in some way, like you don't have the freedom in some way, because you are, relying on this job for a paycheck. You have like health insurance, you have like a salary that pays your bills. And so it almost sounds like you're there because you feel like you have to be there versus because you really want to be there. And I wanted to hear more from you about that.
Yeah, I can really relate to that feeling of being trapped. Even when you said the golden handcuffs, like to me, I feel like that's such a binding position to be in. And you're right. It feels claustrophobic, and it feels like I just want to spread my wings, and I want to, I wish I didn't have to rely on money, but then again, I'm sure everybody wishes that. I just wish I could like spread my wings and jump off a cliff and fly and soar. And But then at the same time, I feel spoiled and bratty for saying that. Like, I mean, doesn't everybody wish they could do that and just like pick up and do what they want to do?
I mean, it sounds like I mentioned this earlier. I'm picking up on some guilt and some self-deprecation about your unhappiness with your current work situation. And the truth of the matter is, if you're not finding meaning and fulfillment from the work, you're not finding meaning and fulfillment from the work. It is what it is in that regard. And there's definitely reason to, this is happening because there's something missing from your life. And you mentioned that you want to be able to like work with people and feel like you're making more of a difference. And I'm wondering what that might look like. I know you said, like, sometimes I feel like I want to fly like a bird, which is, a metaphor for wanting to like break free of like the traps of many of our bureaucratic kind of day-to-day lives. But what would give you like a greater sense of meaning and purpose in your life?
Well, I think I see what you do as my therapist, and I would love to help people the way that you help me, and that feels like it would be really gratifying.
When you think about doing something like that, what comes to mind in terms of logistics?
Well, I like the interpersonal dynamic, not just working with data and numbers, but really connecting on a very deep level. That seems like it would be really fulfilling to me. And really just helping people navigate their struggles seems like, thinking of, helping people think outside of the box. Feels freeing to me in a way because, you're giving them ideas and you're generating kind of I feel like I'm really good at that. I'm good at listening and I'm good at kind of helping people brainstorm some of those ideas. And so why not infuse that into a career direction?
Absolutely. When you think about that coming to fruition, what comes to mind to you?
I don't know. I've been thinking about maybe becoming, a social worker, being a counselor. I'm not quite sure of the logistics, but just in talking to you right now, I feel like that's more of a possibility than when we started the conversation. And so I really want to thank you for just, allowing me to indulge that potential option.
It's my pleasure. Oftentimes, when we're starting to think about things that can be fulfilling, it can feel energizing, but also in terms of feeling like a sense of freedom, oftentimes we have to think about freedom to do things versus freedom from things. There's more empowerment when we think about having the freedom to go back to school or the freedom to be able to take a bicycle ride during the daylight hours, which many of us did not have for many years while working in different settings. And so being able to pursue things that give us meaning and purpose and identifying the things that we do have control over, that we do have freedom to do. And so for yourself, like thinking about like, what is it that I can do? Can I take a night class? Do I want to go back to school? Do I want to be able to talk to other people in the field that I'm interested in and be able to make a shift and what that might look like and all the possibilities that are there for you?
Yeah, that's amazing. We can pause the role play here, but I really want to share with you as I reflect on that role play, um, how really, even though it was a fictionalized storyline, but I was drawing, I think we all probably have been in jobs like that and felt guilty and trapped. I really want to say that I could feel in the pit of my stomach, um, some of that anxiety being released when, especially, I think one of the key features that you talked about was freedom. And it, made me realize that oftentimes we imprison ourselves and we, don't realize that we have the key to, unlock ourselves from what's binding us. And so even when you focused on kind of releasing me from the bind of guilt and saying, it's okay, like you're allowed to you don't have to be always happy with, what your station in life. It's okay to want something else. I felt like you were giving me the freedom of releasing myself from the guilt, which, you know, um, is really, I think, meaningful and important. And I like that kind of component of freedom. And Kathy, I'm wondering, as you watched from an outside perspective, what did you see in that role play?
I really enjoyed watching the role play because it explained kind of how it works to our audience that um, in that situation, the therapist was able to use open-ended questions to get you to share more information and was affirming about what some of your desires and goals were, which opens the door to possibility. And I feel like, Caroline, that just speaks to what you talked about earlier about your commitment to recovery and recovery principles, because that's an important part of recovery, is allowing people space to really think about things like this, which that's true in all therapeutic modalities, but especially in um, a recovery paradigm. So I really enjoyed that. And also just seeing how it allowed you space to do some exploration.
It's my pleasure.
Yeah, absolutely. Kathy, you mentioned the word affirming, and that's exactly how it felt. It felt so validating. And it was, sometimes we don't realize how we're fighting against the current, and just getting that validation. It feels like being, warmed by the sun, and how it really just, it feels very, it just, I don't know, it gives you the fuel to, make decisions and have the courage to do things that maybe you wouldn't otherwise, be in the mindset to do.
Absolutely. A lot of the clients that I serve, we talk about ways that we can, like behavioral activation, which is a very cognitive behavioral, term, but like, what can I do to like give myself like something to look forward to that I have control over, that I have freedom to do? Like, can I take a walk for 15 minutes? Can I read a book for 15 minutes? I call it often microdoses of self-care. I often encourage patients, if they're like, having like a lack of time with their significant other, take a micro date, go out for an hour, have lunch and come back. You don't have to have 3 hours together. And a lot of times those small things in life are the things that make us, and the small things in life are often the things that break us too. And so finding things to look forward to, things that bring us meaning, things that we're excited about, even if it's something small, like enjoying a meal at home, or going to a restaurant, or watching a movie, or reading an interesting chapter of a book. For me, it's like getting outside and like being in the sun and bicycling, or, being able to watch movies or reading interesting things. And so I often try to encourage people to be able to find ways that they feel, a sense of agency, because a lot of times, like you said, people are imprisoning themselves.
Yeah, I think also I want to really key into what you said in terms of giving ourselves permission to, not just tap into self care, but to, like, self care doesn't have to be big and massive. We don't have to, like, hike Mount Everest. We can go on a walk around the block, and sometimes that can just inject us with like a booster shot of, giving us a little bit more energy to, navigate the rest of the day. And so, I like kind of those bite-sized, looking at self-care in terms of bite-sized pieces, as opposed to like like a giant 5-course meal.
Yes, yes, yes. I remember an old English and creative writing teacher who used to say, "Do you eat a sandwich whole, or do you eat it bite by bite?"
I love it. That is a perfect metaphor. I love it. Well, I feel like I have so much to think on, so much to continue with your analogy, so much to digest after our conversation today. I really appreciate kind of hearing about you and your journey, your approach, all the wonderful work you're doing, as well as kind of giving us that sample role play demonstration, which I think was really helpful, and it really shows just the power of that particular technique.
It's been a pleasure.
And I
Yeah.
really enjoyed, as we close, your perspective about working with populations that may be marginalized or disenfranchised. And in your career, how you've worked with people struggling with substance use veterans, women, people with serious and persistent mental illness. And that really reflects on the social work value of social justice.
Yes.
And that's really what you spoke to. And that is so important. So I loved how you intersected that with your clinical side as well. So there's a marriage there between that diversity, equity, inclusion, social justice piece and our clinical work.
Yes.
So thank you for sharing that as well.
Absolutely, my pleasure. That's definitely a population that has always been very dear to me. In the mental health world, what's interesting is there is still stigma within the mental health community working with people that have substance use disorders. And within the substance use disorder community, there's even stigma with patients that are taking methadone or buprenorphine. So there's layer upon layer of stigma even within our field. And so breaking some of those boundaries can be quite powerful.
Well, I think that's so fascinating because I've been thinking a lot about that as it relates to the new drugs for weight loss and the stigma around body image, body positivity, fat shaming, healthy at any size, and then, you know, how we perceive people who use the drugs versus people who kind of continue to work on weight loss with exercise and diet modification and success and failure and judgments around that, which mirrors very much what we see in the substance use world.
That's a really interesting parallel.
Yeah. Wow. This has been such a rich and fulfilling conversation to me. And Caroline, I just want to really express my gratitude for your willingness to share your insights and take time out of your busy schedule to talk with me and Kathy.
Thank you.
Truly a pleasure. And I hope that I'm able to give other people perspective when you share some of the recordings with other people. I love to teach as well. And so it's always a pleasure to be able to impart any knowledge or experience that I have. And it sounds like, you know, you have all the right questions and there's going to be a lot of wonderful information that you gather through this project.
Wonderful. Well, thank you so much. Thank you for supporting our podcast and for just shedding light into so many really important matters.
Thank you for having me. It's a pleasure to meet you, Kathy.
Likewise. Thank you.
Thank you.
Thank you so much.